So welcome everybody to our webinar about EMG for those who don't have any or don't had any contact points to EMG. What is EMG? It's basically electromyography. It's the technology that allows you to track and measure muscular imbalances or muscular activity. And we basically use it for biofeedback training. We will come to that topic later. But first of all, I want to give you a short introduction why we see it as a really important topic. To give you more insights to that, I would like to introduce a little bit to myself. I'm Simon. I'm co-founder and CEO of myoact, and I'm physiotherapist for longer than 15 years now. I never worked without EMG, so EMG was and is still a huge part in my assessment toolbox, as well as in my therapeutic approach to the patient. So when we work with patients, we basically have a situation where some imbalances can occur and lead to pain or injuries. For those who concentrate on structures, we know that there are imaging solutions to get an idea. If there's, for example, a bone issue, then we take X-rays. If we have some issues, for example, with inflammations or soft tissue issues, we probably would choose the MRI or the ultrasound. But for tensions in the muscles, we now start mainly with the palpation, and we question the patient, how he feels. Is he feeling a tension? Do we feel a tension in the muscles? So it's basically more subject feeling, not an objective measurement behind. And this is what we think should be changed based on the fact that EMG can concrete this. When we talk about EMG, as I said, we talk about muscle activity, and we are not talking about strength. So this is a really, really important disclaimer we need to point out, basically because in the common situation, some people define reduced activity with a reduced strength, or counterwise, a high activity with a high strength. Well, there are correlations to that. It depends always on the context, but looking only on the EMG data doesn't give any idea about the strength situation. This is really important to say. If the context is clear and our system is basically context-driven, you can say that a high strength can lead to high activity. Basically, in the moment when we ask the patient to create a high voluntary activity. But high activity doesn't mean high strength, as I said, depending on the context. That there are correlations between muscular activity and strength. There are some researches that has shown that. Everyone potentially knows the moment when he starts with a new movement or a new sport, that in the beginning of learning a new sport, or for example, let's say a new exercise in the gym, there is a pretty fast development in the training and increasing the strength by putting more and more weight on it, until you come to a point of stagnation where you have some kind of a phase where you have a plateau of not developing anymore or not that fast. So researchers, they researched actually that moment, the first 3 to 5 weeks, and figured out that the increasing of the strength is basically driven by better neuromuscular control, measurable also in the brain activity, and no structural changes in the muscle at all. So this is a really important thing, especially in the first time after rehabilitation, after immobilization of muscles or an injury, particular when you have to deload the muscle in some reason. If you then later want to have a progress, for sure, you need to bring changes in the structure muscle by loading and having a load management profile to do an add-on changing in the muscle structure. But there is no way to increase strength without developing better neuromuscular activation coordinations. And this is what EMG is able to measure. So who are the users of myoact? Well, basically, it's from the physicians over physiotherapists to trainers. And we always have some way where they fit together. So the physicians are mainly using it to support their assessments in order to figure out, are there any left to right imbalances, before, after injury imbalances or changes, and for monitoring over a period of time that seeing that the person or the patient is developing his patterns based on the exercises he potentially do or the therapy. The physiotherapist is mainly using it as well as a monitoring tool to objectify the development, as well as testing if his interventions, which can lead to better activity or reducing hypertensions, are really effective. So let's point out, for example, I have a patient with a hypertension in the upper trapezius, and we decide to do a stretching mobilization. Then the stretching mobilization can lead to a better feeling in the patient's feel. But on EMG data, in the majority of the times, we don't see a decreased activity of the neck muscles. So in this case, it's important to tell the person that it's okay to stretch this muscle to gain a better feeling. But on top of that, he potentially needs to activate the antagonist, the lower trapezius, that instantly reduces the hypertension of the upper trapezius in the majority of times. So it's an education tool, it's a monitoring tool, it's a tool to figure out which exercises targets the best the muscle I want to train. And in training, well, it's obvious. It's exactly that. Seeing is the muscle I want to have as a main driver in a specific exercise is really working, and how is he behaving in a situation of progression. So if I have a muscle which is firing in a specific exercise and I'm going to load the exercise, then I want to see also a increasing activity of the specific muscle. If the muscle answers with more load, with lower activity, then I can be pretty sure that this person is compensating somehow. And then I have to decide, do I really want to progress in this individual situation, or do I want to train the compensation pattern, which can be fine, but has to be put into consideration with every other information I have of the patient. Well, the activities are measured in microvolts. They are in the motor neuron. It's like pretty much in the muscle fiber. So as you can imagine, there are a lot of those in each muscle, and only the summation of all these muscle fibers create a EMG outcome that we are filtering. So at the end, what you see on the screen of your tablet is already filtered signal based on the gold standards. So we are not using our own filter technologies. We are using those technologies that are common in the field, even in research. So you can be sure the signal you are seeing is a standard signal that are produced in every research as well. So what we concentrate on is the mind-muscle connection. So we focus mainly on the voluntary ability to activate a specific muscle. So every person should be able to activate a region when he's asked to do so. And that leads to a support of functional diagnosis, as I said, monitoring of training therapy and objectify, and for especially motivate the person. Because what we observed over the last decades is when people see what is happening, they believe it more. The thing is, when you have a hypertensed neck muscle, like the upper trapezius, and you bring your shoulders back down a little bit, and you see how the activity drops down instantly, the patient usually is not feeling released at this quiet moment. He probably feels, well, the tension of the lower trapezius maybe. So the signal out of the body is not always positive, comparing to, for example, massages. The problem is that the moment that leads to a decreased activity is mainly part of the solution. And the moment that leads to a better feeling is giving a better feeling, but it's not treating the solution. Combining both is probably the better way than only reaching out for the symptom. So when we talk about imbalances, we for sure talk about how we can address those imbalances, how we can rebalance those imbalances. And we suggest to follow the well-known motor learning principle, from rough coordination to fine coordination to finest coordination. I will give you an example with some patient example in the next slides, but to give you some insights to that, everything starts with the rough coordination. Again, try to remember the moment when you have learned a new movement. In this moment, you, for example, when you do squats or maybe running, you're not running efficient. You use potentially more muscles that are really necessary in this movement. And the more you do it and the more corrections you do over the time, the more fine coordinated you get. So the body and the neural system is learning which muscles are really useful for reaching my goal. In this example, for example, to run over a period of distance with the lowest amount of stress or endurance problems. And therefore, you need high repeatings. You have to repeat it over a period of time. And to build up a higher resilience, you go to the finest coordination or variation, where you put more, for example, speed in it, or you go into multi-directional movements, or you load it with more weight. So you stress the nervous system controllable more than your goal potentially is, to make your system more resilient. And in the first two phases, the rough coordination and the fine coordination, the biofeedback is a really beneficial tool that helps the people to understand where the muscle is, how the muscle can be integrated, how the muscle can be controlled, when the person is losing the control, because maybe he's feeling that he's losing it, but he's potentially not sure. And this is the moment where you can give them awareness about the situation. In the situation of finest coordination and variation, EMG is mainly used as a monitoring tool. So because, as you can imagine, when someone is doing cuttings or fast movements, he's not able to control it via biofeedback. That is not possible. But it's good for the person who's doing the assessment, the therapist, physician, or the trainer, to observe if that what the patient has learned in the two early stages is really going into the end movement of non-voluntary movements. This is the normal process, and therefore you can divide it into monitoring, biofeedback, and again monitoring. So what is the core of our application? The core of application is the mapping. What is the mapping? The mapping is a context-giving, standardized test procedure for every muscle that is available and measurable via surface EMG. So we have 36 measurable muscle groups that are available in our app. We always have a rest position situation, so a situation where the person just stands and we see is there a hypertension or hypotension. We have the MVA, it's the maximum voluntary activation, so the context behind is activate as hard as you can. Then in the most of the muscles, we have the SVA, it's a selective voluntary activation. So we point out that we only want to have activated one side without having a huge co-contraction of, for example, the other side. And the MMA is the maximum movement activation, where we just concentrate on the balance or the imbalances of left and right. So as you see, every test has its own context. And this is really, really important when you interpret EMG data. Just compare it to the pulse watch. If you have a pulse value, the value alone doesn't give you any idea if it's good or bad. If there you have a context to the value, you can get an idea if it's good or bad. So if you have a pulse of 160, you can say, oh, it's good or bad. If someone is saying, I am running, and then I have a pulse of 160, then potentially everything is right because it seems something normal. If the person is saying, no, I was sleeping and had a pulse of 160, then you have a different context and you can say, it's not normal to have that pulse in such a context. If the person is saying, yeah, but my dream was really tensed, then potentially this context is getting, again, normal for this value. So as you can see, the interpretation of a value changes with the context. And our system is based on this context. So we offer a great context, a clear context that is validated over now more than 30,000 patients with over 120,000 mappings we have done. So we have a range of where are the, let's say, normal activation patterns. So if you do a mapping and you have an end report value, then we put it into the whole segment of our measurements and can say if it's in the normal or not normal cohorts. So we answer the question, how active is the muscle? When exactly is it on or off? And how selective is the control? So here are some examples for two of the muscles, the lower trapezius and the vastus medialis and vastus lateralis. As you can see, we have rest position. We have the MVA pulled down both shoulders. And when we say this is always maximum, then only the left one, the right one, raising arms, side and front. And in the vastus, pretty much equal to the rectus femoris, is knee extensions, straightening the knee in sitting position, a lying position, doing squat and single leg squat. Behind every text, there is a huge knowledge base we have in our application that's giving you some insights. What does this test mean? Why we are using this test? And what does it mean if one of the tests is pointing out that it's potentially a red number based on the fact that we are using the traffic light system with green, yellow, and red. So just to give you some insights how it can look like, when you have activated, for example, maximum voluntary activation, you can see in clear numbers here as microvolts, 642 to 478. That means that this person created this value in a specific context. And then we have a balance score. So how imbalanced he is, it's basically 74 means it's an imbalance of 26%. Everything over 80% balance, or to say less than 20% imbalance is clinical totally irrelevant. So we don't focus on 100% balance. We focus on clinical relevant balance. And we figured out over the last 15 years using EMG in physiotherapy that there is a huge tolerance. So what we say is every imbalance lower than 20% is, as I said, not clinically relevant. Every imbalance lower than 40% has to be matched with different other informations you can get from the patient and put it into consideration if this needs to be corrected or not. And everything below, when we come to imbalances higher than 40%, or let's say balances lower than 60%, then we suggest really to intervene. We have a rest position, as you can see here. You see in the middle a picture. The white lines are like the line where hypertension begins is basically 20 microvolts. And the person on the picture has the sensors on the upper trapezius. So this is an example for a hypertensed upper trapezius. And it's instantly measurable. And if you have a treatment plan, you can do it. The patient can do the exercises, and the next time he's coming back, you put him in directly in the same position, and you can figure out if he has decreased values comparing to this measurement before. And then we have the balance score. As you can see, we have an overall balance score, which is a summation of all the balance score from each test. So the more experience you get, the more you can point out every single test to get an idea if there's an issue. But the relevance lies into the summation, so in the overall value. So the same what we have in clinical testings. Only one clinical test maybe doesn't say enough, so we do more to get an idea. And in the moment, if you have like bad results in every test, then it gets really interesting for the patient. So if we have figured out a imbalanced situation, or let's say decreased activity of a specific muscle, then we directly hop into the biofeedback training. Just to give you an idea of how long does it take, a mapping takes for one muscle group less than 3 minutes. So it's a test battery. Each movement is done in 3 repeatings. And if you really go through, it's less than 3 minutes. So you really go fast into the biofeedback moment to find out and figure out which exercises addresses the muscle the best. The patient is seeing it. From now, we have a corrective exercise base, so the patient can see it on a video. You can film it with the mobile phone of the patient. He needs to do it at home. And the next time he's coming back, we suggest the earliest, maybe after 1 week, he comes back, and then you can remap the situation and see if there's any progress in reactivating the structure. Just to give you an example, here we have an imbalance of vastus medialis and lateralis. So the left bar is the vastus medialis and the right bar is the vastus lateralis. So this imbalance, what you see here, is a common one after knee issues. And in the majority of time, the therapists or the trainers say, okay, we have to train the vastus medialis in a dominant way. So we tested a lot of exercises that we have seen in the internet, what we know from other therapists or trainers. And unfortunately, the majority of the exercises don't address the vastus medialis dominant. Here you have an example, and this is basically the same patient, just a few minutes later. We used this exercise to address the vastus medialis. So this exercises we figured out works really like in the majority of the time, but not always. Let's say 80% of the imbalances can be treated with this exercise, but that's not the point. It's the point to say, like, if I have an idea to target a specific muscle, I should measure it. Otherwise, I potentially don't target the muscle and I keep exercising the patient in his false pattern. So this is basically what we wanted to point out. And if the patient is doing this for a period of time, and in this case it was 5 weeks, we can do a remapping and we see that he developed from 75% balance to 91, just integrating this one exercises. And that doesn't mean that he has to stop everything else what he's doing. So the people we are working with 12 Bundesliga clubs right now. They all keep on training. They just take 1 or 2 exercises that are really addressing the imbalances on top of that, and the system is reconnecting. And this is what is measurable, and this is for sure motivating the person to maybe do exercises that doesn't always feel comfortable. And yeah, that was pretty much rough and fine coordination exercising. Here we have some example of a pro athlete from the Olympic hurdle runner. So he is integrating the peroneus longus in a more, let's say, variation. So we come to more and more into the sport-specific movement. So you can integrate it in different ways, always to give the, in this case, athlete an idea of, okay, do I really know how to control a specific muscle, and what do I need to do in my body to create, for example, a high activity? For the gluteus medius, we like to choose the closed chain situation, so step up, and then you have different progress situation. First, just lifting the leg from a chair. Second, putting away the chair and going all the way. The third one is going from a hip extension into a knee flexion. And the fourth one is creating a higher speed. So velocity is also one variation. And we can observe, is he always increasing the activity, or is he losing the control in one of these variations?